stress. We also have hormonal regulation of carbohydrate metabolism. Hormonal regulation of carbohydrate metabolism. And for this particular system, insulin is involved in the hormonal regulation. Insulin is the number one hormone that are involved. What are the functions of insulin? It lowers blood glucose. How does it achieve this? How does insulin achieve the lowering of blood glucose when there is excess blood glucose? Number one, it stimulates the process of glycolysis, which is the process of breaking glucose down. It stimulates the process of glycolysis. Number two, it stimulates the process of glycogenesis, that is conversion of glucose to glycogen. And also it stimulates fatty acid synthesis, whereby glucose are synthesized into fatty acids. We also have the second hormone under this hormonal regulation of carbohydrate metabolism. We have glucagon. Glucagon raises the blood glucose, unlike insulin that lowers the blood glucose. Glucagon stimulates glycogenolysis and gluconeogenesis. It stimulates glycogenolysis and gluconeogenesis. Other hormones that are involved in the hormonal regulation of carbohydrate metabolism are epinephrine, which is adrenaline. This one causes emergency glucose release. We also have cortisol. Cortisol increases gluconeogenesis too. And then growth hormone. This one reduces glucose uptake. So these are the hormones that are involved in the hormonal regulation of the carbohydrate metabolism. Then we also have diabetes mellitus. These are disorders of carbohydrate. We have diabetes mellitus. Remember, we are looking at carbohydrate metabolism and disorders. Diabetes mellitus happens to be one of the disorders of carbohydrate metabolism. And we have type 1 diabetes, which is the autoimmune destruction of pancreatic beta cells. Type 1 diabetes is autoimmune destruction of pancreatic beta cells. And it's a case of absolute insulin deficiency. It's a case of absolute insulin deficiency. And usually begins in childhood. Symptoms are polyuria, polydipsia, weight loss, and ketoacidosis. These are the symptoms of type 1 diabetes. Polyuria, polydipsia, weight loss, and ketoacidosis. Type 2 diabetes are usually insulin resistance plus impaired insulin secretion. These are the conditions that can result, that normally result of type 2 diabetes. When there's insulin resistance, or impaired insulin secretion, where the body does not respond to the insulin that was produced. So insulin will not be able to reduce the blood glucose, or where there is impaired insulin secretion, that is insufficient secretion of insulin. So that is the condition. This situation results into type 2 diabetes. And these are common in adults, and most cases related to obesity. So the features of type 2 diabetes are hyperglycemia, fatigue, and recurrent infections. The other type of diabetes is gestational diabetes. This one occurs in pregnancy, and it is a glucose intolerance situation during pregnancy. Glucose intolerance situation during pregnancy. And complications of this are ketoacidosis, hyperosmolar hyperglycemic state, retinopathy, nephropathy, neuropathy, and cardiovascular diseases. So these are the complications of gestational diabetes. Now, we have situation of hypoglycemia. The one we have mentioned are cases of hyperglycemia. Hypoglycemia is a situation of low blood glucose that is less than 7 milligrams per dl. And the causes of hypoglycemia could be excess insulin, fasting, alcohol, or liver disease. So symptoms of hypoglycemia situation are sweating, tremors all over the body, confusion, seizures, and coma. Another disease, we have dealt with diabetes now, both the hyperglycemia and the hypoglycemia. Now, another disease is glycogen storage disease, GSD, glycogen storage disease. And number one of them is von Ghake disease, type 1. This one is the deficiency of glucose-6-phosphatase. Deficiency of glucose-6-phosphatase results into von Ghake disease. And in this situation, there will be severe hypoglycemia. And occasionally, there will be enlarged liver. Another disease under this is Pompe disease. Pompe disease type 2. This one is lysosomal acid maltase deficiency. And it results into cardiomegaly. Another disease condition is Cori disease type 3. This one is as a result of the branching enzyme defect. The branching enzyme defect. Another type of disease is McDowell disease type 5. McDowell disease type 5. This one is muscle phosphorylase deficiency. And it is exercise intolerance. Another disorder of carbohydrate metabolism is disorders of galactose and fructose metabolism. Disorders of galactose and fructose metabolism. The first one is galactosemia. Galactosemia. In this situation, galactose 1-phosphate uridine is the enzyme that is deficient. It's the enzyme that is deficient. And the symptoms of galactosemia is jaundice. We also have vomiting, liver disease, and cataract. Another disorder of galactose and fructose metabolism is hereditary fructose intolerance. Hereditary fructose intolerance. And in this case, it is aldolase B that is defected. Aldolase B that is defected. And it results into hypoglycemia after fructose injection. There will be hypoglycemia after injection of fructose. Another one is lactose intolerance. This one, it is lactase enzyme that is deficient that will result into lactose intolerance. And the symptoms are bloating, diarrhea, abdominal cramps after milk intake. Another one is pentose pathway disorders. Pentose pathway disorders. And in this case, we have what we normally call the G6PD deficiency. The G6PD deficiency. And it is a chromosome X linked. It is chromosome S linked. And it leads to hemolytic anemia. And it's usually triggered by infections or by eating or consumption of fava beans or by the use of some anti-malaria drugs. So a G6PD deficiency patient, if they are exposed to any of these anti-malaria drugs, fava fever, or infections, they will manifest this pentose pathway disorder, and they will have hemolytic anemia. Hemolysis will take place in their blood. Now, let's quickly look at the laboratory investigations that are related to carbohydrate metabolism. Laboratory investigations that are related to carbohydrate metabolism. The common one that we are familiar with is the blood glucose test. The blood glucose test, and these are either fasting blood glucose or random blood glucose, or OGTT, oral glucose tolerance test. Another investigation is hemoglobin A1C. This one is a long-term glucose control test. It reads the glucose in the system for the past 3 months. So it is the A1C hemoglobin of the red blood cells that are measured, and that one binds with glucose. And because red blood cells has 3 months lifespan, 90 days to 120 days. Therefore, when you estimate the content of blood of the A1C content of the blood. That will give you an idea of the glucose over the 3 months in the body of the individual. So the other one is insulin and C-peptide level test. Insulin and C-peptide level test. This one will evaluate insulin production. Another test of carbohydrate metabolism is liver function test. Liver function test, where you test for all the enzymes that operate in the liver. And this one is for gluconeogenesis and glycogen metabolism. We also can do some urine tests. One, glucose in urine, ketone in urine, and then reducing sugars in galactosemia and fructosuria. So we can do reducing sugar test on the urine to screen for galactosemia or fructosuria. So, in summary, carbohydrate metabolism involves breaking down glucose for energy. It involves storing glucose as glycogen. It involves producing glucose when the body is in need of it. And the common disorders arise when the hormones fail, e.g. insulin, or when the enzymes malfunction, e.g. G6PD or GSDS. And then transport or absorption issues also occurs occasionally. So these are the things I want to share with us on carbohydrate metabolism and disorders. Carbohydrate metabolism and disorders. Let us look at the let's look at pathophysiology of diabetes mellitus. Pathophysiology of diabetes mellitus. Diabetes mellitus is a chronic metabolic disorder, that is characterized by hyperglycemia, which results from defect in insulin secretion, insulin action, or both. And long-term uncontrolled diabetes affects carbohydrates, fats, and protein metabolism, and leads to microvascular and macrovascular complications. We have type 1 diabetes mellitus, and the mechanism of this is autoimmune destruction of pancreatic beta cells, absolute insulin deficiency, like I said earlier on. So just a little overview on the pathophysiology mechanisms. A little overview of the pathophysiology mechanism. Type 1 diabetes mellitus is insulin dependent. So autoimmune destruction of pancreatic beta cells mediated by CD8 T cells. So it is genetic predisposition, and it is triggered by the environment, like viruses in the environment. Like I said earlier on, it is an absolute insulin deficiency case. So it leads to hyperglycemia, it leads to lipolysis. That is, there will be increased free fatty acid, which will result into ketone bodies, and then it will result into ketoacidosis. So this is the mechanism of the pathology. And hyperglycemia that will cause increase in fatty acid cells, ketone bodies will be produced and result into ketoacidosis. And then the muscle protein and the weight loss. Now let's look at the pathophysiology of type 2 diabetes mellitus. Type 2 diabetes mellitus is non-insulin dependent. It is non-insulin dependent. And the key mechanisms are there will be reduced cellular response to normal insulin. That is what we refer to as resistant to insulin. Reduced cellular response to normal insulin. And it is caused by obesity, especially central viscera or sedentary lifestyle. These are caused by obesity or sedentary lifestyle. So those have been implemented to be responsible for type 2 diabetes. Then we have fatty acid accumulation disrupt insulin signaling too. And then there's beta cell dysfunction. There's chronic hyperglycemia, which leads to glucotoxicity, and then eventually reduce insulin secretion. When there's chronic hyperglycemia that leads to glucotoxicity, the beta cell will not function well. And the malfunctioning of the beta cell will result into reduced secretion of insulin. We call it the incretin defect. And then there will also be liver overproduction of glucose, that is, increase in gluconeogenesis in type 2 diabetes. So features of this is hyperglycemia without ketoacidosis. Then hyposmolar hyperglycemic state will also be possible. So what are the consequences of these metabolic situations? In hyperglycemia, there will be reduced uptake plus increased hepatic glucose output. In glycosuria, glucose will be greater than renal threshold. So there will be glucose in the urine. In lipolysis, as a result, the cause will be insulin deficiency. For protein catabolism, insulin is anabolic. Now, the long-term complications of this metabolic disorder are microvascular, in which case it results into retinopathy, it results into nephropathy, and it results into neuropathy. Retinopathy, the eyes, retina of the eyes, nephropathy, the kidney, and then neuropathy, the neurons. And there can also be macrovascular complication. It is macrovascular when it results into coronary artery disease or peripheral arterial disease, or when it results into stroke. Those are macrovascular complications. And other complications are diabetic foot, poor wound healing, and increased infection risk. Increased infection risk. So, key takeaway: type 1 diabetes is no insulin. Type 2 is insulin resistance. That is gradual beta cell failure. And then both lead to hyperglycemia and metabolic imbalance. Long-term glucotoxicity, multi-organ damage, leads to multi-organ damage. Early detection and control prevent complication. So that is for the pathophysiology of diabetes mellitus. Now let us look at the diabetes ketoacidosis. Diabetes ketoacidosis. Now, what is diabetes ketoacidosis? What is diabetes ketoacidosis? Diabetic ketoacidosis is a life-threatening condition. It's an acute complication of diabetes. It's a life-threatening acute complication of diabetes. And it is characterized by hyperglycemia. Diabetes ketoacidosis is characterized by hyperglycemia. It's also characterized by ketosis. It's also characterized by metabolic acidosis. Metabolic acidosis. It is most common in type 1 diabetes mellitus, but can occur also in type 2 during severe stress or illness. It is most common in type 1 diabetes. Diabetic ketoacidosis is most common in type 1 diabetes mellitus, but can occur in type 2 during severe stress or illness. And then the pathophysiology of diabetes ketoacidosis is one, insulin deficiency, where there's absolute or relative deficiency of insulin, especially during stress. It leads to reduced glucose uptake by cells, that is hyperglycemia. So insulin deficiency is one of the pathophysiology. The second one is counter-regulatory hormones, as I explained earlier on, increase in glucagon, cortisol, growth hormone, and catecholamines. And also it stimulates gluconeogenesis, glycogenolysis, and lipolysis. Then there is ketone body formation in diabetes ketoacidosis. Ketone body formation. Lipolysis will result into increased free fatty acid. And then the increased free fatty acid will be converted in the liver into ketone bodies. And these ketone bodies will accumulate to form metabolic acidosis. That is, I said, I want to repeat the ketone body formation. It is lipolysis that will result into formation of free fatty acid that will be increased. And then the free fatty acid in the liver will be converted into ketone bodies, which are set to acetate beta hydroxybutyrate. And then we can also have osmotic diuresis. Osmotic diuresis in the situation of hyperglycemia we call lead into glycosuria. Glycosuria will lead to polyuria. Polyuria will lead to dehydration, and then there will be electrolyte loss. So there will be osmotic diuresis. The diagnostic criteria of diabetes ketoacidosis, parameter that we normally investigate is the blood glucose, normally greater than 250 milligrams per DL or greater than 30.9 millimoles per liter. And then we test for arterial pH. Normally, the arterial pH will be less than 7.3. 7.3. And then we screen for serum bicarbonate. And then the serum bicarbonate will be less than 80 milliequivalent per liter. And then we check for ketone in the urine and also in the blood. So occasionally we have up to 4 pluses of ketones in the urine and in the blood. And then sometimes we test for the anion gap. The anion gap will be greater than 12. We occasionally check for osmolarity too, but the result of this is actually variable in most cases. So what are the clinical features? The clinical features of diabetes ketoacidosis. Number one is polyuria, excessive production of urine, and that will lead to dehydration and lead to polydipsia, which is excessive drinking of water because of dehydration. And this will lead to weight loss occasionally because of the loss of water. There's weight loss, there's fatigue as clinical features. That is the early features. But the progressive features are abdominal pain. Progressive features, clinical features are abdominal pain, nausea and vomiting, rapid deep breathing that we call Kussmaul respiration. Rapid deep breathing. And then we also have condition of fruity odor breath, acetone smell, fruity odor breath, acetone smell. That is progressive. But for the severe clinical features, in severe clinical features, there will be utter consciousness in which the patient will go into coma. And sometimes the patient go into shock, and sometimes there is a situation of hypotension and tachycardia. So these are the severe clinical features. Utter consciousness in which the patient go into coma, shock, hypotension, and tachycardia. Now, what are the precipitating factors of diabetes ketoacidosis? In the category of infection, a sample of precipitating factors are UTI, urinary tract infection, also pneumonia. Mostly, these are things that examples of infection that triggers diabetes ketoacidosis, urinary tract infection, and pneumonia. In the situation of non-compliance, we have missed insulin. Missed insulin. That is, a patient that's on insulin and missed the insulin, it it can precipitate the condition of diabetes ketoacidosis. Another situation is stress and illness. Stress and illness. Stroke, trauma, missed insulin will cause stress and illness and precipitate diabetes mellitus, diabetes ketoacidosis. Also, there are some drugs that could precipitate diabetes ketoacidosis. Examples of these drugs are corticosteroids and thiazides. They are drugs that can precipitate diabetes ketoacidosis. Also, we have new onset type 1 diabetes mellitus. New onset type 1 diabetes mellitus at first presentation. What are the management principles? The management principles of the condition of diabetes ketoacidosis. Step A, for patients that are unconscious, open their airway, let them have access to air so that they will assess consciousness. 2, breathing, respiration. C, circulation, that is, give them IV fluid. D, introduce dextrose and electrolyte monitoring. And C, insulin therapy. And then potassium replacement process. So the key management points are, start with IV fluid first, normal saline, for patient that is suffering from diabetes ketoacidosis. And then IV insulin infusion, regular insulin, monitor the potassium, because insulin reduces serum potassium. So you monitor the potassium. If potassium is less than 3.3 milliequivalent per liter, correct the potassium before insulin. Then add dextrose when glucose falls less than 200 milligrams per DL to continue insulin safely. And then treat the trigger issues, infection or not, treat them. You want to compare diabetes ketoacidosis? It is a complication of diabetes mellitus or diabetes type 1 or type 2 diabetes. So complication if untreated, like I said earlier on, it can result to cerebral edema, which is common in children, shock, arrhythmias due to hypokalemia, or even death. So diabetes ketoacidosis is a situation of hyperglycemia plus ketosis plus acidosis. Let me also take hyperosmolar hyperglycemic state. That will be the last topic I will talk about for tonight. Hyperosmolar hyperglycemic state, HHS. What is HHS? HHS is a serious acute complication of diabetes. It's a serious acute complication of diabetes. And it is characterized by severe hyperglycemia. It is characterized by severe hyperglycemia. It is marked by hyperosmolarity. Marked hyperosmolarity and profound dehydration. Yes, profound dehydration. It's characterized by profound dehydration and then absence or minimal ketosis compared to diabetes ketoacidosis. So it mainly occurs in type 2 diabetes mellitus, typically in elderly patients. It mainly occurs in type 2 diabetes mellitus. Now, the pathophysiology of hyperosmolar hyperglycemic state that is called HHS. 1, insufficient insulin action, but not complete deficiency. It's a situation of insufficient action, not complete deficiency. So enough insulin to prevent ketogenesis, but too little to control blood glucose. Too little to control blood glucose. Enough insulin to prevent ketogenesis, but too little to control glucose. Number 2, severe hyperglycemia. Severe hyperglycemia. Excess hepatic glucose production and poor cellular uptake lead to extremely high blood pressure. Excess hepatic glucose production and poor cellular uptake of glucose lead to extremely high blood glucose. In a situation that the glucose would be greater than 600 milligrams per dl or 33.3 millimole per liter. That is severe situation of hyperglycemia. That is the second pathophysiology of HHS. HHS is hyperosmolar hyperglycemic state. Hyperosmolar hyperglycemic state. We also have situation of osmotic diuresis. Osmotic diuresis. In this situation, we have high glucose. And this high glucose leads to glycosuria and leads to water and electrolyte loss. When there's glycosuria, that is almost resulting to polyuria, there will be water and electrolyte loss. And then there will be profound dehydration, up to 9 to 10 liters lost. That's osmotic diuresis. We also have hyperosmolarity. Hyperosmolarity. This one is loss of water without equal electrolyte loss. So in this situation, the serum osmolarity will be greater than 320 MOSM kg, greater than 320 microosmolarity per kilogram. And this can lead to utter consciousness or coma. Remember, we are talking about a situation of HHS, which is hyperosmolar hyperglycemic state. Hyperosmolar hyperglycemic state. Now, these are the diagnostic criteria. We do plasma glucose, and typical finding for this condition, it will be greater than 600 milligrams per dl. That is 33.3 millimole per liter. We do serum osmolarity too. Serum osmolarity will be greater than 320. We do arterial pH, it will be greater than 7.3 near normal. We do bicarbonate, it will be greater than 18 milliequivalent per liter. We do ketones. It will be absent or mild. Anion gap less than 12. And if you do the serum potassium, it will either be normal or low. And then when you check for the mental status of the patient, it will either be altered, that is confusion to situation of coma. So earlier on, I was saying we wanted to compare diabetes ketoacidosis with hyperosmolar hyperglycemic state. In HHS, it occurs in type 2 diabetes, but DKA occurs in type 1 diabetes mellitus. Onset of HHS is slow, is in days. Onset of DKA is rapid, is within hours. Glucose in HHS is greater than 600 milligrams per dl. Glucose in DKA is greater than 250 milligrams per dl. Ketone is normally absent or minimal in HHS, in hyperosmolar hyperglycemic state. But in diabetic ketoacidosis, ketone is always present. pH is greater than 7.3, which is normal or mild in HHAS. But pH is less than 7.3 because it is acidotic in acidosis. In the case of DKA, that is diabetes ketoacidosis. Dehydration is always severe in HHS, but dehydration is always moderate in DKA. The mortality rate in HHAS is always higher, that is 10 to 20%, while in DKA it is lower, that is less than 5%. Now, what are the clinical features of HHS, hyperosmolar hyperglycemic state? The only clinical features are one, polydipsia and polyuria, and then also lethargy and weakness. These are the only clinical features of hyperosmolar hyperglycemic state. Now we have progressive. We have progressive clinical features. We have severe dehydration as one of the progressive clinical features. We have dry mucous membrane as one of the clinical features of progressive clinical features. We have tachycardia. We have hypotension. So these are the progressive clinical features of hyperosmolar hyperglycemic state. And then we also have neurological clinical features. Neurological, in this case, we have confusion, we have delirium, we have seizures, and we have coma. Now, what are the precipitating factors of hyperosmolar hyperglycemic state? In the category of infection, it is UTI and pneumonia that normally precipitate this condition. Then for poor glycemic control, it is mixed medication. Then for stress and trauma that precipitate this condition, it is a mixed insulin, stroke, and surgery. And then for medications that can precipitate HHS, steroids and diuretics can precipitate HHS. Then for dehydration, hot climate condition or situation of old age can precipitate HHS. Management of HHS. Number one is aggressive IV fluid. That is the first line treatment. You start with isotonic saline, and then you replace deficit over 24 to 48 hours. The second stage is low dose IV insulin, only after hydration has started. You have to hydrate before you begin to give the insulin. Then you avoid rapid glucose drop so that you won't risk cerebral edema. Avoid rapid glucose drop. And then correct the electrolytes. That is, you monitor the potassium, you monitor the sodium, and then you treat underlying cause, which you treat with antibiotics if it is infection, or you manage missed insulin, stroke, and drug effect. So, for this evening, key takeaway under HHS, it is situation of extreme hyperglycemia that is greater than 600 milligrams per DL or 33.3 millimole per liter. Then, situation of hyperosmolarity, situation of severe dehydration, but there's no acidosis. It occurs slowly, mostly in elderly type 2 diabetic patients, and then fluid replacement is the most critical treatment because of the severe dehydration. And then ketosis and acidosis are minimal or even absent, unlike diabetes ketoacidosis. Then there's higher mortality than diabetic ketoacidosis to delay the recognition. So on this note, I want to stop tonight. I don't know when we can continue our lecture tomorrow. It appears you have already fixed a lecture for 6 p.m. tomorrow.
Yes, sir.
Okay, so
I don't know if tomorrow morning is convenient for you, sir.
Time in the morning, 8 a.m.
Anytime in the morning, sir.
Okay.
I don't know the rest of the class. I think 8 a.m. is fine.
Or you want 7 a.m.
Okay. That time, some of us are just Waking up.
Okay,
8
can
a.m.,
we
sir.
then plan for 8 a.m. tomorrow morning?
8 a.m.
Yes,
is fine,
8
sir. 8 a.m. is
All
fine,
right,
sir.
8
It's okay.
a.m. tomorrow morning.
Yes,
Yes,
sir.
I'll send the link privately to you now. I won't
All
put
right,
it
sir.
on a. Okay, I don't know if you are on the chemistry platform.
I am
Is
there
there
too.
now?
Because that's where I share the link in ab initio.
Oga is
But the
there
one I
now.
saw there was for tomorrow.
Yes, the
No,
one
that is
for
general platform, sir.
that's general platform, sir. Yes,
That means
sir.
I'm not.
Where I
So I have to
discuss
go and
with
check.
you, sir, where I discuss with you is for chemical pathology. Where I
Yes,
discussed with you yesterday.
That means I'm not in the chemical.
you are
You are
I'm
there,
not
sir.
there. Maybe you need to add me.
Sir,
Huh?
that is the platform I discussed with you yesterday. When
Yes,
I
where we
asked, when
agreed.
are we having Dr. Akintaju and Amushon, that is the ChemPath platform, sir.
Yes, where you said today, and that's where I picked the class time for. So that's where I picked it from, and that's why I did the link. You are already there.
Okay, that's the platform you are referring to.
Yes, sir, that's for ChemPath,
clinical
sir.
chemistry.
All right, no problem.
Yes, sir. So, but
Sorry
I'll still
for the
send it
mix
to
of
you.
this.
I'll still send it to you privately, sir.
Sorry for the mix up.
No,
Yes,
no
sir.
problem, sir.
So tomorrow morning will not be like that. I have problem.
Well done, sir.
So
All right, thank you very
link,
much. I will prepare the note and send to you.
yes, sir. That would be very lovely, sir. Thank
All
you
right.
so much for today.
Okay.
Let's go, sir.
All right, good night. God bless you.
Amen.
Good night, sir. Amen, sir. So, thank you all. Good night, sir. Good night, ma. Madam Patience, I hope my work is going on. Oh.
Good night, everybody.
Night. I like that. I like that tiny voice. So that is telling us good night.
Na small Nwachukwu.
Okay. Oh. Auntie Chidimma.
Kí ni time wo ni lecture ọ̀la báyìí?
8 o'clock, 8 in the morning.
Ẹ fẹ́ kí n jí lórí bẹ́ẹ̀dì ni.
Ẹ máa jí pẹ̀lú ògo Ọlọ́run.
Àmín náà, àmín. No problem. Ẹ jẹ́ àṣẹ nǹkan tá a ní ṣe ká kúrò.
Ẹ jẹ́ á ṣe á ti wà behind. Ẹ jẹ́ ká tètè ṣe gbogbo nǹkan tá a bá fẹ́ ṣe.
Hematology ti ṣe tán.
Ọlọ́run micro ló ṣì kún lẹ́nu ẹ̀. Hematology ti ṣe náà ti fún wọn last assignment gan.
Kí lorúkọ ẹ̀? Micro ó ṣàfihàn méjì.
Ẹ má wọrí, a máa catch up.
Na exam dey wait for January or February so they don finish.
Ẹ má wọrí, a máa catch up. Títí wá tiẹ̀ máa better, a sì máa fresh wọnú exam mi.
No problem. Tá bá lè parí lectures lọ́dún yìí. So that
by God's grace. We will do review by January.
And then
Yeah,
prepare
revision by
ourselves.
January.
Abeg.
Àfiṣẹ́mà. Àwọ̀ wa ló kùn sí i. Once we start, ká máa jẹ́ kí tempo yẹn continue like every other 2 days. Ká máa ní lecture.
Àbí? Àṣà ti mú Wednesday and Saturday sí so kánjọ a máa ṣe bẹ́ẹ̀. Then we should
No
open
problem.
our mind to any lecturer for Friday. Ẹ má jẹ́ aṣọ
No, Friday is okay. Kí là ń ṣe? Tó bá ti jẹ́ anytime from 6 o'clock, we should be available. Ẹni tí ó bá dẹ̀ lè wà available, a máa wo recording.
No. So that tó bá ń sọ̀rọ̀ báyìí, a máa follow tá a bá rí screen.
Yes.
So that bí kò bá lè share screen àti ní soft copy, a máa wò ó tẹ̀lé. Kánjọ.
Àbí.
Wọ́n máa send
No wahala.
direct. Àwọn máa prepare.
No wahala.
All right, sir.
Ó dá mà, ó dárọ̀ mà.
Good night, yeah.
Good night, ma. Yes, ma.